YouTube started, Chetan bhai.
Fine, fine. Good evening, Dr. Bhaskar.
Uh, Good evening, good evening.
Thank you for
Hi.
joining in time.
Oh, yeah. I'm 1 minute before 10. Good evening, Manish ji.
Good evening, sir.
Good evening,
How are you, sir, now?
Bhaskar, Manish, and Chetan.
Good evening, sir.
Good evening, sir.
Yes,
Namaste,
good evening,
sir.
sir. Just wanted to tell that I called you because Dr. Kulkarni was on the way and he was in traffic. So I said, okay, at least somebody should join. But now he has joined. So
Good
by chance
evening,
he is
Dr.
not there.
Kulkarni. No, yes, left.
He is there. Dr. Kulkarni is there. No, by chance he is not able to connect, then at least Bala sir will be there, no? Because this is Tanu ma'am will be presenting.
My God. Right. Come
You
on.
know, he is there. He is there.
Yeah, that's why I called him.
I am here to learn.
You are there to teach, sir. We are there to learn.
No. I am here to learn new things.
Kulkarni sir has network issue probably. He again left.
I'm here, so whenever you want to start, you can start.
Yes, ma'am. Yes, ma'am. Good evening, Kulkarni sir.
Good evening.
Chetan bhai, you're mute.
Good evening, good evening. Finally, you could join, right?
Yeah.
Yeah. I called Bala sir. By chance, if Pramod Kulkarni sir is, not able to join, we should be having somebody to tackle ma'am's bouncers.
I think we should start.
YouTube started, no?
Hi, YouTube started.
Okay, fine. Good evening, Dr. Palani. Thank you for joining.
Very good evening, my dear. Very good evening.
OPD is over
Yeah.
or going on?
Just now finished and came.
क्या
Good
बात
evening,
है?
Paladi. Yeah, very good evening, Pramod. Very good evening, SBS sir.
Hi, Praniraman and Pramod.
Good evening, sir.
Good evening, good evening.
Good evening, Pramod ji, Palani ji.
Very good evening.
Good evening, Dr. Tanu.
Hi, good
Nice
evening,
to see you.
everyone. Yeah.
Good
Hello,
evening,
hello.
madam.
Very good evening.
Today it is Pramod Square. Pramod Joke, Pramod Kulkarni, both are there.
Oh, fantastic. And the three-piece, Pune, Pramod, and okay, Kulkarni.
Yes. So I think we should start, right?
Yes.
Yeah. Okay. Good evening, friends. At the outset, thank you all for joining. And this is gradually becoming one of the most popular webinar series because it is absolutely coming from the experts. And most important thing is the cases are very interesting as Dr. Tanu ma'am is presenting, and we are there having one expert, ID expert, to face the case actually as if it is happening in front of them, because this is nothing, no clue whatsoever has been given to the person expert. So for that, this time we have a wonderful academicians from Pune, Dr. Pramod Kulkarni sir. Everybody knows him. He is absolutely on the dot whenever we are discussing cases. So I am very sure that he will be able to manage ma'am's questions and the cases. So welcome all. And first, I'll request Chairperson Dr. Bhaskar Shenoy to welcome all.
Good evening, everyone. At another academic feast by Tanu Singhal and aptly answered by Pramod Kulkarni. And thank you for doing this wonderful job. And it is being benefited, and I get good feedback from everyone telling that it is one of the fantastic webinars that we are having. And I'm so happy that this kind of academic activity is going on in our academy. Second thing is, I request the NCPAD is coming fast, and everyone, please uh, register for it. It is going to be academic extravaganza with the national and international speakers. We are having around 10 international speakers and a NCPAD with a difference, with different kind of discussions and other things. So unless the delegates come, it is very difficult for us to do that, and won't look good also. With the few delegates, you do a big conference, it's not good. So I once again request everyone who have not registered, please register earliest today itself. With those two few words, I hand over it to Dr. Chetan for further proceedings.
Yeah, fine. I think the stage is all set, and I'll request Dr. Tanu ma'am. I'll just acknowledge the presence of Dr. Pramod Jog, Dr. Nikhil, Dr. Balasubramanian sir, Dr. Devjit, and Dr. Palani. And Tanu ma'am, you can share the presentation and start. Dr. Vijay Ole sir called that he will not be able to join because of some guest at home. And Dr. Baldev Prajapati will be joining soon. Thank you.
Thank you all. And with that, we start the case. I mean, the purposes of these case discussion is, not to, these are all cases where there are diagnostic dilemmas. And the purpose is not to reach the diagnosis, but how we travel along the way and to give messages to the audience about what mistakes were made during the process of reaching the diagnosis and how we can avoid those mistakes when we see these cases, later in our clinical practice. So with that, I'll come across this case, I'll discuss this case, and this case has a very special meaning for me because I identify with this case. And this is the case of a 15-year-old child, which I saw in 2019 when he was studying in Kota for JEE entrance, because my child, my son, who was also 15 years at that time, and he was also keen to get admission to JEE. So I really identified with that kid. And he started having low-grade fever and back pain, okay, when he was in Kota. And the parents were staying somewhere in UP, but this child was sent to Kota, and you know that Kota is like the place where many students go for preparing for JEE, and often they don't take good care of their food, etc. So he started having low-grade fever and back pain, and he was seen by some general practitioners and maybe pediatricians in Kota, and he was investigated after a couple of weeks, where they found that he had leukocytosis with his white cell count being 15,000 with 78% neutrophils, thrombocytosis. He had an elevated CRP and ESR. His Vidal was done, which was negative. Dengue was negative. No blood cultures were done. His MP was also negative. MAN2 was done, which was negative. IGRA was negative. The patient was given some antibiotics and antimalarials, but his symptoms continued. So at this point, I would like to pause and ask Dr. Pramod Kulkarni, in a PUO like this, do you really see any role of doing any MAN2 and IGRA and for the diagnosis of TB? And second is there any role of antimalarials in this kind of patient? Would you even think of malaria with these kind of blood reports?
Thank you very much, Tanu ma'am, and thank you, PIDA, for giving me this opportunity. Looking at the case scenario given by Tanu ma'am, the first impression is this is an adolescent who is staying out of his hometown. He has 2 weeks of low-grade fever and back pain. And with these reports, I am thinking of some inflammatory lesion, paraspinal or spinal. With this, I'll be looking at the localization and precise structural evaluation of the problem and then thinking about the etiology. Rather than, and Mantu and IGRA have no role in diagnosis at all. No question of antimalarials at all, in my mind at least.
Yeah, you've made a very important point that, the role of these Manto and IGRA is only for diagnosis of TB infection. When we are thinking of giving prophylaxis, for TB contacts, they have no role at all in diagnosing TB disease. And, you cannot think of malaria in a patient who has high platelets, etc. So we must not be doing any kind of empirical antimalarial therapy. Neither we be using these tests for TB infection for diagnosing TB, and neither should we do them to rule out TB, because 20 to 30% of patients with TB will have negative Manto and IGRA. And what Dr. Kulkarni said, that we have to do structural evaluation before we proceed ahead. And as he said, we did do the structural evaluation was done, and MRI of the spine was done. And as you can see with the MRI, you can see that this is the D12 vertebra, and you can see in the D12 vertebra there is there is involvement, there is marrow edema that you can see. Then you can see that there is collapse of the intervertebral disc between D12 and L1. And you can also see that there is some paravertebral collection. You cannot see the nodes here, but the MRI people reported that there were some abdominal nodes. And of course, I don't have the CT chest report here, but some non-specific CT chest was also done in this patient, but they also reported that there were some non-specific infiltrates in the right upper lobe. So with this low-grade fever and with this kind of spondylodiscitis and some infiltrates in the upper lobe, what kind of differentials would come to your mind? What would be the uh, possibilities that you would think of, and how would you proceed from here to make a diagnosis?
As we have done imaging, which is telling us there is a lesion in D12 and with paravertebral collection as well. With this history of 2 weeks, this is definitely a subacute infection, maybe a chronic one also. So the subacute to chronic infection, under which I will definitely entertain tuberculosis, but not go with IGRA or Mantu. Tuberculosis is the first thing to be ruled out, and there are some other atypical chronic infections which can behave like tuberculosis. So here what I really feel, in a 15-year-old primary vertebrodiscitis, I am not aware of any risk factors like trauma or any other issues in the past about the risk factors. So primary vertebrodiscitis of subacute onset, I will entertain first tuberculosis and subacute infections like brucellosis and some other uncommon infections as well. As there is suppuration, as there is paravertebral collection, definitely this appears to be a suppurative infection. Again, that is the only additional point I can comment about.
So you would think of TB and brucellosis, and yeah, we did ask because this child was staying in the hostel there in Kota. So yeah, obviously he might be having food from outside in the hostel. So we don't know, he might be taking food, milk which may not have been boiled properly. So that is, so apart from TB and brucellosis, is there any other differential that you would entertain here?
The other uncommon uh, bugs which can cause osteomyelitis of this kind, I have not seen the uncommon organisms which can come this subacute way or a prolonged acute, let us say, it's within borderline of that. Unusual organisms like Kingela and maybe some tropical infection, unusual infections.
So there is somebody in the chat who's also written about eosinophilic granuloma. I think they mean something like histiocytosis. I think somebody has mentioned. Okay.
Uh, at this age, with primary vertebral involvement and suppuration, which is their collection, I won't think of LCH or any other possibility. This is definitely a suppurative illness and primarily involving the vertebral body. So I will not go about the other inflammatory conditions with
Okay.
that suppuration or collection.
Okay.
Maybe this could be partially treated pyogenic osteomyelitis as well with
Okay.
paraspinal abscesses.
Okay. Could be like staphylococcus, for example,
Yeah, it
isn't
can
it?
very well be.
Yeah. Yeah. So TB, brucellosis, like you said, a bacterial spondylodiscitis. Would you think of a malignancy like a lymphoma or something here?
That is to my mind last because I again said that is the only lesion which we have to screen for other areas. We have to look at other areas also. Why should lymphoma it's okay destroying the vertebra, but again causing a suppurative collection? Maybe we can combine as a remote possibility combination of primary lymphoma with secondary infection or something like that. But that is stretching it too far.
So what would you do now? Now, how would you proceed? Would you like kind of think of giving empirical anti-TB treatment to this patient, or would you want to do a invasive procedure to confirm the diagnosis?
See, we have got a structural evaluation done. We have got the site involved. We need the tissue for a diagnosis, which is the final thing which will determine the therapeutic actions. Nothing empirical in this child.
Absolutely.
Good
So,
collection as well as good processing of the specimen which we collect.
so what would you send the specimen for? We do a CT guided biopsy, and what all would you send the specimen for?
Basically, as we are entertaining the partially treated bacterial spondylodiscitis, I'll go for gram stain, Zn stain, aerobic culture. Anaerobic, I won't think of, but still I'll do it with good amount. Then AB, Gene Expert Ultra, Midget, definitely. These are the things. And maybe I will do with a remote possibility, a KOH stain as well. And PCR, bone and joint infection, which is now available, which will give me some odd organisms which are fastidious, which cannot be picked.
And will you do a histopathology as well? You will send a histopath as well. Dr. Kulkarni, we've lost you. You will send a histopath specimen as well. I think we've lost him a bit. Okay.
I think his connection is lost.
Okay. So anyway, so he is very right in saying that we will have to send specimens for bacterial and TB culture and gene expert. So Dr. Bala, please fill in if he is not able to join again. So we did so he's very right. We would send specimens for all this. So he undergoes CT guided biopsy of the vertebral lesion. It shows that there is infiltration by acute and chronic inflammatory cells, but no granulomas, no malignant cells seen. TB culture, I mean, which came later, was negative, but gene expert was not done, which is quite a shame. Bacterial culture, and that is actually not surprising because, we keep talking about in all our conferences about gene expert, but, maybe in metropolitan cities, it's very common, but this specimen was done in Jaipur, this biopsy, and they didn't do a gene expert, which is quite a shame. And bacterial culture was sent, which showed Pseudomonas aeruginosa sensitive to most antibiotics. And these are the reports which you can see that there was bony tissue and then it grew Pseudomonas species. They didn't, kind of get whether it was, sorry, it was not aeruginosa, it was Pseudomonas species. And it showed that it was sensitive to most antibiotics. So the question is, how do you interpret this report? Like, what do you make of it? Like, we never thought of Pseudomonas osteomyelitis in this patient who was so How do you interpret these reports? Dr. Kulkarni, are you back with us?
As you rightly said, the isolated Pseudomonas species, they have not mentioned clearly what it is. So it can be a bug which resembles Pseudomonas, but is not Pseudomonas. That is the first thing I will entertain. There are many mimickers of Pseudomonas, and under Pseudomonas, it can be something unusual also under Pseudomonas species. So,
So is,
amyloidosis is one of the, though it usually presents respiratory illness or abscesses. This could be amyloidosis or any other atypical bug under Pseudomonas species or which is mimicking Pseudomonas. And it is pan-sensitive. That's quite surprising these days when we are in era of Pseudomonas being resistant to many of the drugs.
so
Unless there
you
is some immunodeficiency, I will not entertain this Pseudomonas primarily causing spondylodiscitis without any risk factor.
so you think this could be Burkholderia pseudomallei?
Yes, very likely to be.
But this patient doesn't really have any risk factors. He did not belong to a melioidosis endemic area because he was in Kota, which is quite a dry area. And he did not have any risk factors for melioid. You still think it could be melioid?
No, it's a possibility. Of course,
And he
see,
didn't
it's
have
a
any risk factors, like he was not diabetic, he was not alcoholic, he didn't have
any
any disease.
freshwater pond, bath, or water activity like that. Had he been anywhere at outing in the rural areas of Rajasthan nearby?
Okay,
That
fair
is
enough.
another thing. And I will again entertain brucellosis here because again brucellosis can come this way and can mimic Pseudomonas by early. I need to know about the methods of identification and I will go for further narrowing down on the species and what kind of Pseudomonas or Pseudomonas like organism is. So I will ideally prefer in this case further better identification methods if I have got a MALDI-TOF
So
or
I just want to
PCRs.
ask you, can this Pseudomonas be a contaminant also? Suppose the specimen was not collected properly and transported properly. Can this Pseudomonas actually be a contaminant of the biopsy specimen?
We have got Pseudomonas species only. We don't know exactly which particular organism it is. So it is difficult to say whether it is contaminant or pathogen.
Okay. But yeah, we must also consider the possibility that it could be a contaminant. Apart from the fact that you said that it may have been some other atypical organism like Pseudomallei or maybe a Brucella, which was misidentified because it was probably not done by Vitek or something else. It was a kind of maybe a conventional identification. Pseudomonas may also be a contaminant of biopsy specimens. Anyway, the patient was treated with IV cefoperazone, sulbactam, linezolid, and ciprofloxacin. Now, can you actually comment on these choice of antibiotics which were given to the patient?
Can I please look at the culture report?
He was sensitive to, all the antibiotics like piptazo, imipenem, meropenem, amikacin, gentamicin, tobramycin, ciprofloxacin, levofloxacin, aztreonam. And even if you look at, polymyxins, they have not given the zone. So it was probably polymyxin, not given a zone. It was resistant to colistin. So that tells us that it may have been actually pseudomallei. So one thing is that Burkholderia pseudomallei is resistant to colistin. So yeah, you are right. It could have been Burkholderia pseudomallei.
And what was the child treated with?
He was treated with cefoperazone, sulbactam, linezolid. So do you have any justification for giving linezolid
No,
to
no,
this
no.
child?
With the spondylodiscitis, which is a bone infection with Pseudomonas, any bone infection, you have to consider the bone penetration of the antibiotics. And no way I find this cefoperazone, sulbactam, and linezolid to be the initial choice for treatment of any of the osteomyelitis of this kind with gram-negative bug. Ciprofloxacin, I do agree with good penetration of ciprofloxacin. If it is sensitive, that should be good enough. But I would not have chosen cefoperazone, sulbactam, or linezolid here.
So there was transient improvement followed by recurrence of fever and back pain. So the child didn't really get better. And now it was July. So he had presented in May, June, ये सब चक्कर चल रहा था. Biopsy showing some inflammation, pseudomonas, got these antibiotics. Didn't initially he got a little better. Then it was July. Now he was re-investigated. Then his counts went up, platelets went up, ESR and CRP went up, and then they did imaging again. So initially there were few infiltrates in the chest, but then on repeat CT you can see now he has developed nodular lesions in the lung, and they were also splenic and liver lesions. And when the doctors found that he had developed these lesions, they felt that there is something else happening with this child, and they started the patient on first line AKT and ciproflox and linezolid. And then after 2 weeks of treatment, they just stopped the antibiotics and they gave him only first line AKT. So you obviously this child is not getting better with got better with the antibiotics, and now his disease has progressed. He's got nodular lesions in the lung and liver and spleen. So what do you think is happening to this child, and do you agree with this approach?
Uh, the things are not working for the child with this therapy and with the regimen they have chosen. And the child is initially the infection, I assume it was restricted to the spine or the vertebra and the paraspinal area. Now it has disseminated, not only not responded, it has disseminated to pulmonary lesions and reticuloendothelial, splenic and liver lesions. That is the extension with the counts and ESR, CRP and high platelets saying again a chronic persistent pyogenic infection which is persistent. So I really feel like the regimen they have chosen is not going to work. With these splenic liver lesions, again brucella comes to my mind. That is one thing which has not responded to the regimen chosen and now has disseminated. But pulmonary lesions in brucella are I've not at least heard of. But the splenic and liver lesions make me think of brucella as a prominent possibility, or any other atypical organism which can spread like this, which is not responding to quinolones, beta lactams, and these two. So it is something out of this. And it is definitely not tuberculosis, not at all tuberculosis. I will never choose anti-tubercular in this child.
Okay. So I'm just so you are thinking that this is not looking like TB to you. This sounds more like brucellosis, though you feel that the nodular lesions in the lung are not like brucella.
Another possibility I will think of, if this is a fungal osteomyelitis, it is less likely to be because the child seems to be immunocompetent. Don't have details of his immunocompetence or other risk factors. But very few fungi can actually cause this kind of disseminated disease in an immunocompetent child. But definitely a fungus, malioidosis cannot be ruled out with this. Brucella, malioid, and a possibility of fungal infection, I sincerely think of.
I think, I was looking at the chat while you were speaking. So many people are saying that this could be malioid, and I think they are right in an extent because the first pseudomonas grew and there was acute and chronic inflammation on the biopsy. And then the specimen was colistin resistant. So it could have been Burkholderia pseudomallei, and pseudomallei is known to involve the lung, liver, and spleen. The only thing is that this patient didn't belong to a malioid endemic zone and he didn't have risk factors for malioid. Then brucella, people are mentioning, somebody is saying that Rajasthan is an endemic area for brucella. So brucella can cause nodular lesions in the lung. We had one child who had presented with nodular lesions, and of course a blood culture grew brucella. Third, somebody, Dr. Baldev Prajapati, is mentioning about malignancy as a possibility. Somebody's talking about vasculitis. Dr. Bajapati is also saying that Pseudomonas is a contamination. Dr. Bala is saying that he wants to investigate for a CGD. Then people are saying that we should do a CT guided biopsy again. Then tuberculosis, Wegener's, of course, Wegener's as a possibility, which is a right thing that it could be an autoimmune. Okay. How will we reach a diagnosis? So we have mentioned about the differentials, but how are we going to reach the diagnosis of what it is?
Basically, as we have narrowed down the list of probable pathogen, looking at malioidosis, brucellosis, a possible fungal, we have to focus with that one with serology and direct evidence as we have already done. I don't know whether the initial specimen was had undergone extended culture and Brucella PCR, had it been processed with Brucella PCR, as well as we don't have information about serology of Brucella in this child. Melioidosis, I think only thing which can help us is the serology. I'm not aware if we have serology, but PCR will be the only thing, or a culture, the specific culture needs of melioidosis. These are the two things I will refocus upon. If needed, I'll go for definitely a recollection of a better specimen and subject it to these advanced tests wherever they are available.
Yes, so I think they do serology for melioid. I think in Mangalore, they also do some PCR tests in blood. Brucella serology, yes, definitely. And I think we should try and do a biopsy again for this patient, isn't it? From maybe from the lung, from the nodules or whatever. Anyway, so agreed that TB, everybody thinks that TB doesn't look likely here. Now this patient is having 2 months, this patient is taking TB treatment in Jaipur from July to September. He has persistent high fever, weight loss, severe back pain. There's no clinical response. A repeat CT is done. And as you can see, there is increase in lung lesions and lesions in liver and spleen. So I will not again ask the same question because everybody feels that this patient is not on the right track. He shouldn't be just getting empiric anti-TB treatment because the diagnosis is something other than TB. And therefore, we should go in for trying to re-establish the diagnosis by doing a biopsy and serology and try and get a diagnosis. So this patient then comes to Kokilaben Hospital. And when he comes to Kokilaben Hospital, he sees the pulmonologist because he obviously has a lot of lung lesions. So they go to the pulmonologist and this patient undergoes a BAL and transbronchial subcarinal lymph node biopsy. Now this BAL, which was done, it is cytology negative. The gene expert ultra comes positive trace with rifampicin resistance indeterminate. The lung biopsy also was done, which shows inflammatory cells. They did a blind lung biopsy because there were so many lesions. The lymph node, the subcarinal lymph node, is expert negative, and the biopsy shows non-specific inflammation. No aerobic samples were sent because when this patient was seen by the pulmonologist, he thought that we are dealing with a case of possible tuberculosis. So this is the report of the cytology. So it says paucicellular smear showing no malignant cells, EBUS TBNA from the subcarinal node shows lymphocytes with few histiocytes, well-formed granulomas not seen. Then if you look at the transbronchial lung biopsy from the right upper lobe of the lung, it shows in focal dense inflammatory infiltrate comprising of histiocytes, neutrophils, and lymphoplasmacytes. Few epithelioid histiocytes are seen. Well-formed granulomas are not seen. Langerhans giant cells not seen. Caseous necrosis not seen. Reed-Sternberg cells not seen. No evidence of malignancy. Focal acute on chronic inflammation with ill-formed histiocytic granulomas. Kindly correlate with gene expert and acid-fast bacilli culture findings. This is the gene expert report. MTB complex in lymph node aspirate is not detected, but in the BAL, MTB is detected trace, RIF resistance is indeterminate. So this is what is happening now with this patient who has now been sick for almost 4 months. To just summarize, he had presented with back pain. He had the the spondylodiscitis. Biopsy from there had shown acute and chronic inflammatory cells. The expert was not done. The culture had grown pseudomonas, maybe not identified correctly. He had received antibiotics with which he didn't get better. Then he was on AKT for 2 months, with which he didn't get better. Now he has large number of liver, splenic lesions. He also has lung lesions. And now he has got biopsies done from the lung, bowel, and lymph node. And these are all inconclusive. The only positive thing which we have got is that we've got a BAL gene expert, which is trace, BAL gene expert ultra, which is trace positive. RIF resistance is indeterminate. Now, what do you think? What do you think it is? Do you think
Looking
that
at
this...
looking at
Hello? Dr. Kulkarni, I can't hear you properly.
Pramod, not heard. Pramod, your voice is unclear. Your voice is not clear, Pramod.
Sir, please switch off your video and talk. We lost him. He's not there.
So maybe I would rather, if till we get him back, maybe I would ask somebody else, maybe Dr. Bala, to comment on this.
Oh God. Yeah. You see, all the three are possible, but let me put the chances one by one. Paradoxical reaction coming after 2 months, unusual. Usually occurs within about first 1 month, but later cases also have been reported. And I didn't see lymph nodes, much of lymph node response. And I didn't see the HIV report, however uncommon it is. I'm sure HIV should have
Yeah, HIV was done. HIV was negative.
negative. Yeah, that's one thing I would have done. Drug resistance, primary or secondary, very much likely because of the reports that we have on our hand right now. And the third, there is still a possibility that it is more than TB. It's not TB and it's some other disease where there are granulomas without an infection starting from sarcoid to other things. And I was not sure whether an ophthalmic examination was done for ruling out uveitis and an echo whether it was done. And maybe at this point of time, with no diagnosis obvious, I'm not sure whether I would, without cultures, I would bet on any of the three. I'm cornered. And I wouldn't give any empirical ATT at this point of time, that too for drug resistance until I get cultures.
But how do we go from here? Because
may I come in?
Yes, Dr. Kulkarni, glad to
So
have you
as I
back.
said,
Yes.
I'm not happy with the site of specimen collection because it's not primary site of problem. Leave apart that trace ultra expert with indeterminate. I will ignore it because it's a ball sample. We don't know, the endoscopes are always contaminated and it's not convincing at all. Mijit previous was negative. The child is not responding to DSTB regimen at all. Suppuration is there. The only additional information I get here, that as you said, little histiocytic, and again the lymph nodes, mediastinal nodes, I don't know whether they are diseased or not, what the TBNA is going to give us. I don't believe in this. I will go for the primary site aspiration, again biopsy of the vertebral lesion and collection there, a sumptuous, reasonable size of specimen and good microbiological histopathological workup of it, and sending additional, if nothing comes out, for immunohistochemistry. That will be my next line of action.
I would have done a PET CT for this boy earlier to find out where all their lesions are, other than liver, lung, and bone.
Sir, it is not going to be of any help. It's not going to tell us what kind of etiology it is.
Yeah,
In
yeah,
any
agree.
infection or
Agree.
malignancy, it is going to show the activity only.
Yeah,
But it is going to tell us where to sample from.
yeah. Site it will help us identify probably a site where you can do something which is non-invasive. That is the usefulness. That is a usefulness. Not that no PET CT is ever going to give us etiological diagnosis. It's going to help the physician focus on the most likely area from which he can get the tissue. For example, now you are saying the ball is a contaminant. If the ball is a contaminant, I am. Yeah, so to disprove that, if you get the same report of rifampicin resistance in TB from some other site which is easily accessible, it will make things easier for me because I'm caught. I can't start ATT now. I can't start drugs for drug resistant TB. I can't give steroids for paradoxical reaction because I'm not sure what it is. And I don't have evidence for any other disease. So to get more evidence for the primary disease, definitely I would zoom on a PET CT and then.
So I think the comments are so good. I mean, you have hit the nail on the head, because what Dr. I mean, both the comments are excellent, because they said that this is a problem of going to the wrong sampling site. We have not taken the specimen from the right site, and that is so very perfect. So anyway, this was thought to be MDR TB, and MDR regimen was started in this patient because of want of I'm just going by what happened in this patient. And this regime was started, but there was no clinical response. And midget cultures came negative. And what to do now? And I think the experts have already answered the question. And at this point, I'm just trying to see what people have said on the chat. That BAL, liver biopsy, PET CT culture biopsy, HIV. Okay. So I think the experts say, and what Dr. Kulkarni said, that they would want to sample another site and take a good specimen, and they would have to do a good immunohistochemistry and try and reach a proper diagnosis, because this is not leading anywhere. So at that point, parents kept asking whether this is really TB, since none of the histopathology reports confirmed the same. Need to relook at the diagnosis. So we reviewed the imaging. So we looked again at the imaging again. And then the radiologist said that the lesions in the liver and spleen looked suspicious. And they said that we must probably do a sampling on the abdominal nodes, because the abdominal nodes were large and were more amenable to biopsy, because the splenic lesions not amenable to biopsy, the liver lesions were not amenable to biopsy. It was difficult to biopsy from the nodular lung lesions. And then we told the parents that we have to do another biopsy. And the parents were really tired because the patient had already undergone 2 biopsies. But we told them, like what Dr. Kulkarni said, that we cannot give an answer without a biopsy, because we can't keep on giving empiric therapy, because this patient, you remember, has already got 3 empirical therapies. First, he got the antibiotics for the Pseudomonas, then he got the first line AKT, and now he's getting second line AKT. So we went ahead, and any guesses what it turned out to be? Before I reveal the diagnosis, any guesses from the experts?
Some malignancy.
Yeah.
It should be malignancy.
Yes. Dr. Baldev Prajapati was right. He also mentioned the FNAC showed high-grade anaplastic tumor with plenty of mitosis. So we did a core biopsy from the lymph node. It showed Hodgkin's disease of mixed cellularity. And the PET scan we did, which showed multiple nodes and bony and liver and splenic lesions. It was stage 3 Hodgkin's he treated. And I just called the child today. And, I was so happy to know that he had cleared his JE entrance in first attempt, after he took his chemotherapy. In fact, his son, he and my son took JE in the together in, 2022. And he's studying in IIT Roorkee Chemical Engineering final year. I mean, look at that kid. Despite going through Hodgkin's, he did so well. So, I mean, and I remember Dr. Kulkarni, you said that because there is suppuration, you will not think of a malignancy, but even malignancies can suppurate, because if a tumor outgrows its vascular supply, it can suppurate. Okay. So the question here is that why did the previous biopsies not yield the diagnosis? That is the first question I have. Any thoughts on that? I mean, are you muted or have you left? Or Dr. Bala?
Yeah, you see, the only situation I can think of as a common pediatrician, a scenario of malignancy fooling the pediatrician, the most common one is steroid therapy. That's one. Second is, of course, not enough sample. Sometimes in a lymph node, there are cases in which the first biopsy had not shown anything, the second biopsy had shown. It all depends on where you do the biopsy. Okay, and third one, sometimes when you do biopsy, the surgeon or the orthopedic surgeon might not do it at the most what do you call dirty area. They may pick up an area where there is not much disease. That can happen with regard to lymph node or even a bone lesion. And last but not the least, here I don't know, the biopsy was done from a suppurative, so-called suppurative lesion or a hard lesion. If it had been a hard lesion, I'm sure the lymphoma would have been very, very obvious. Other than that, I don't know. I don't know that much pathology to tell you why and in whom Hodgkin fools clinicians like us. I don't know, honestly.
Yeah, so I think, Dr. Kulkarni, are you there? Would you like to add something here?
No, sir has already said the lapses or the possible explanations for the negative biopsy. But it's really a foxing case.
So, yeah, so sampling error, because, when you do a needle biopsy, you may not go to the first is that you may not hit the right area. Sometimes if you hit the necrotic center, you may not get enough, you may get only dead tissue where you may not get the right material. If you have gone to the edge, you may not get it. And even when the lung lesions were targeted, they were not, they were bronchoscopy guided. So you may not have got the right material. So that is the reason. And that's why what PET CT may help us. Because when you do a PET CT, then you may actually, you may get the site where there is the maximum SUV, and you may actually, so like what Dr. Bala said is that the PET CT does not give you the diagnosis, but the PET CT will help you, point the site from where you might get the most representative tissue. Now, the next question is that why did the BAL show the expert ultra positive? You had already answered that question,
Yeah,
Doctor.
trace call most of the time you have to take with pinch of salt. And the scopes are known to be contaminated with AFB. And unless there is a clinical background, other pointers towards tuberculosis and some microbiological proof, the trace call is always a suspicious thing. Unless the child or the patient is in very critical condition, one should not treat and take it as positive.
So that is a very important point, that when you're looking at expert ultra, you have to be very careful, because ultra has high sensitivity, but it has low specificity also. So the specificity is lower than the normal gene expert. So ultra is good for extrapulmonary TB. But for pulmonary TB, it may either be because of contamination of the bronchoscope, or it may be due to latent infection in the lungs, because everybody is half, 1/3 of the population is latently infected. So it may pick up latent infection. So if all other things are not fitting in with TB and you just get a trace call on the ultra, you have to be careful and not base your decision to treat just on the basis of expert ultra. It was a red herring in this case, because you were always thinking of TB, and then you got the expert ultra with indeterminate rifampicin resistance, and the patient was not responding to first line AKT, and then you thought that it could be DRTB. So that was also a learning point in this patient.
Just one comment, Tanu. See, in a patient like this who has drug-resistant tuberculosis with a trace report from expert ultra, it's very, very unlikely that the smears are AFB negative. Very, very unlikely. After all,
So the smears will be negative, sir, because if the smears are positive, your expert will be coming very high.
no, what I'm saying is a patient who's having such a chronic disease, who's having a drug-resistant tuberculosis, multiple sites, the AFB yield will be very high. That's what I'm saying.
The load will be high.
Yeah,
You will
load will
not
be
get
high.
a
Load will
trace
be
call.
high, and
Yeah.
AFB positivity rates are very high.
Yeah.
And even the reports of ultra will be not trace, and it will be significant.
Yes, it will
That's
be.
my comment.
Yes. So you're right, sir. So if he has so much of TB in the lungs, like multiple nodular lesions all over, you are likely to get a much, either a low detected or a medium detected ultra. You will not get a kind of a trace detected. That's true. So it didn't fit in, but so I just wanted to say that this patient had two microbiologic red herrings. The first red herring was the Pseudomonas in the first biopsy, which was probably a contaminant. And again, the expert ultra in the second biopsy, which was the second red herring, which made you suspect that this patient is having an infection as the cause of his disease. So this was a patient with a malignancy with two red herrings in his reports. So finally, I would like to end with the messages that please remember TB mimics. Okay, when we started this case with a low-grade fever and back pain, and that spondylodiscitis, the first thought which came to our mind was TB. But remember, you have TB mimics, which include brucellosis, which include Langerhans histiocytosis, which include lymphoma, especially Hodgkin's disease. Because Hodgkin's disease is a relatively slow growing lymphoma, not like NHL, and it can mimic TB. And of course, autoimmune diseases like Wegener's. Wegener's GPA, granulomatous polyangiitis, can also mimic TB. Especially, it can come with vertebral destruction and it can come with nodular lesions in the lung. In fact, I remember a case, though it was not a child, but it was an adult who presented with vertebral osteomyelitis. And I treated that case as TB, and later he presented with nodular lesions in the lung and renal involvement, and he died because there was a delay in diagnosis, thinking that it was a case of TB. So remember the TB mimics. Of course, we can also add sarcoid to that. Then there is little role for empiric therapy, and the experts have already talked about that in this case. They have already always stressed that please go for biopsy. Always choose the biopsy site carefully and interpret the investigations carefully. That means always don't go, on face value. If the reports of the investigations do not match with the clinical presentation, always take them with a pinch of salt. I think with that, I would now turn it over to the experts for their comments and then to the moderator.
Only one comment. Brilliant, Tanu, matched by brilliant Pramod. Thank you very much.
Dr. Baldev Prajapati had written for malignancy right in the beginning.
Dr. know what just I wanted to convey that certainly if we try to analyze and the way in which I was thinking, just let me share. As you started the story, that the problem started with the involvement of the vertebral bodies and the paraspinal problem. Then we'll have to think that really is it the primary site of the problem or really it is the secondary? If I consider that it is really it is the primary site of the disease, then probably we'll think for the tuberculosis or something like that. I think even not the brucellosis. Brucellosis has to be very frank. Why I was a little bit biased. I'm getting many patients of the brucellosis from Rajasthan. And I forgot the name of one of the pediatricians who gets the brucellosis in hundreds in his own town, confirmed. And I have even participated in discussion. And therefore, Rajasthan, that is just somehow, I don't know exactly, even he could not explain. But
Dr. Khatri.
yeah, Dr. Khatri, yes, Dr. Khatri. But I think brucellosis behaving in this way was not convincing. That is one. It can probably, maybe even the disease at some other place, and now even the brucellosis meningitis or brucellosis osteomyelitis, yes, they are known as the complications. But starting from this, I will say bone, were not convincing. That was the issue. Second, I think as meridosis we have to consider. I think Pseudomonas is not quite obvious, convincing that it is a and I think in our daily practice we get the contamination very commonly with the Pseudomonas. Another thing regarding then whether the real is secondary, then the malignancy comes first. And all of us know that primary may be somewhere else, secondary may be even anywhere all over the body. Probably skeletal system is common. And therefore, any malignancy, whatever we consider, we'll have to keep in mind. Third, even the group of the disease, that any disease whose systemic disease, but involving the various organs, particularly the vaginous disease, sarcoidosis, they start with, I will say, beginning of the disease anywhere, either the lung or the skeletal system or even the liver, and then with the maybe the dissemination or with the severity of disease may spread to other places. So I will say that was my ways of thinking. And as you provided more some informations, probably with this was the differential diagnosis. I think one more comment already you have emphasized, but very common, I think, the practice. Whenever you go, because now we know that for diagnosis of tuberculosis, we are more depending and more even considering that gene expert. Whenever we get with the trace or indeterminate, I think don't jump for the diagnosis and even to treat the patient. We may keep in mind one of the possibilities, but better to go for confirmation. And at least 3-4 occasions I remember that turned out to be something else. One of the patients was the lymphoma, ultimately, in my own unit. That even the trace, every time even the macrobal, 2 times he said it is a trace indeterminate and turn out to be the lymphoma. So I think indeterminate trace, something comes in the report. Don't consider the diagnostic. I will say think
Yeah,
something
no,
else.
no, but I just want to tell you that the reason ultra has better sensitivity is because
Yeah.
of the trace call. Because expert may you have till very low, but you don't have trace. So many times, I just don't want to give the message here is that when you get traced, it's not TB. 9 times out of 10, it will be TB only.
Agreed.
Okay. I just want to give that message because I don't want people from here going with that message that, it's not TB. This was an unusual case where it didn't turn out to be TB. But in your day-to-day practice, you have a pleural effusion, you have lymphocytes in the pleural fluid, and your expert ultra comes trace. 9 times out of 10, it will be TB only.
Yeah.
Okay, so you have meningitis, you have done an expert ultra, it comes trace, please think it is TB, okay? Because otherwise, people will start dismissing that ultra. Ultra is a wonderful test.
Wonderful test.
It is revolutionized the diagnosis, especially for childhood TB where the bacillary load is very less. So we should not make out the expert ultra to be a villain, okay? Just because of this case.
Yes.
Okay, 99 times out of 100, the expert ultra is a true positive. Okay.
Tanu, just one comment, one comment. For this patient, I'll tell you, I would have definitely done TB quantiferon. And
It was done.
no,
It
what
was
I'm
done.
saying, I'm coming to it. if the TB quantiferon is negative, I mean, see, I'm not saying it rules out TB completely. The chances of this child having TB will become very low in my.
So it was done in the beginning, sir.
The
IGRA was negative.
Yeah, I would be, see, in a case like this, I wouldn't be doing Manto, but I would definitely do a TB quantiferon for more than one reason. For example, you have a vasculitis, you're going to make a diagnosis of vasculitis, you're going to start steroids. Anyway, you're going to rule out latent tuberculosis. And negative quantiferon, if I have it on my table, I mean, the possibility of, for example, well-nourished adult or adolescent, I'm not going to think of tuberculosis. I'm not going to think of tuberculosis. Not that it rules out 100%. Like any other test, it doesn't have 100% sensitivity and specificity, but it's far better than Manto. Previously, we always used to do Manto in a well-nourished patient. If the Manto is negative, we always used to think it may not be tuberculosis. So on a similar note, TB quantiferon negativity makes disseminated tuberculosis in such age very, very unlikely.
You're right, sir. And in this patient, we discussed that on the first slide. This patient had a IGRA and MANTU done, which were both negative.
Yeah.
So although it was done right in the beginning, but that was also one negative thing which would have made us think that
Yes.
this is unlikely to be TB because he had like TB. So yeah.
On the same line as Tanu said about Gene Expert Ultra, to tell you it is one of the best tests. And recently we heard at CI Discon that 6 out of 7 times a trace call with indeterminate, it is to be treated as a DSTB. DSTB. So it doesn't take away anything from the merits of the test, but the clinical context is more important. Especially the scopy specimen, you have to be a little more cautious about the contamination of the scopes. But otherwise, if the clinical context is there, and if the ultra is positive in trace and it is indeterminate, you have to treat it as DSTB most of the times, and you will be correct 6 out of 7 times.
Right, point well taken. Dr. Chetan, is he there?
Yeah, I think Chetan is not there. Dr. Pramod Jog is there too. Yeah, Manish is there. Dr. Manish.
Yeah. Sir, one question I had, as you told the scope contamination will be more of atypical mycobacteria, right?
No, it can be anything. It can be anything.
See,
Okay.
because if the person has done a bronchoscopy for a pulmonary TB patient, okay, before, and then if the scope has not been cleaned properly, and then the bronchoscopy has been done for another patient, you can have MTB also.
I think, Manish, when we were using the same needle for the lumbar puncture in the past, the patient who was not having the meningitis, we make the meningitis after the lumbar puncture. So that was very common story in our residency. And I think now this can be with the bronchoscope. So then we'll have to take the care. And that can be happen with even the mycobacterium, not only the atypical. Yes.
So gene expert will be positive only otherwise in 2 cases, MTB and M. bovis. Rest of the all mycobacteria will be negative, right?
Yes, NTM will be negative.
Yeah.
Yeah.
AFB will be seen on Z stain, but the gene expert is negative.
Yes. And culture and genetics will be only differentiating point between MTB and M. bovis,
Yes.
if you want to.
Yes, culture will also not differentiate because in culture, the MPT64 will be positive for both MTB and M. bovis. But if you do pyrazinamide susceptibility, that may differentiate. But now the problem is that pyrazinamide susceptibility is not easily available. So the only way to differentiate MTB and M. bovis is to do whole genome sequencing.
So thank you very much, ma'am. It was a really great discussion, especially when it comes to TB. There is always new things to learn.
Manish, Pramod Jokes comments. Pramod
Yeah,
Jokes.
sir. But still we have comments. Yeah. Pramod Jokes, sir.
No, nothing to comment. Actually, I'm so glad that Tanu has presented this unusual case where everyone thought of tuberculosis and it of course, malignancy fooled the pediatricians, and it was a great discussion where we had highlighting of the sampling errors, Pseudomonas as a contaminant, and limitations of Expert Ultra. And I must say that the boy cleared the IIT JEE entrance test in the first attempt, and Pramod also cleared the IET, that was the infection entrance test with Tanu. Okay, so I'm, uh, congratulations for the
Very good,
excellent
very
approach.
good. Good comment.
Yeah, yeah, yeah. And Tanu already in the beginning only said that it's not the diagnosis, but it's the approach which matters, and that was exemplarily proved after today's discussion. So thank you, and also appreciate the comments by Dr. Bala, Baldev, and Monish. Thank you.
Thank you very much, sir. Dr. Daruru, sir, comments from you.
Am I audible first?
Yes,
Yes,
yes, sir.
Yes, Darur.
Loud enough.
Sorry, no, sorry, I could not join. So there are no comments from my side. But one thing is definite, bacterial infection. Second comes tuberculosis. Third in our life is always malignancy. We have to keep that in mind.
Yes, sir. Palani Raman, sir, are you there?
Nothing from my side. Nothing from my side. Thank you. Thanks for wonderful discussion. It's a nice
I just want to say that please let other people also present on this platform. And maybe next time somebody else can do the presentation and somebody else can be the expert.
I think Palani Raman will do that.
Yeah.
Or Bala sir.
I don't mind returning the compliment to Tanu. Certainly would not. It would be a pleasure.
Yes, yes, sir. Yashwant, sir, you can just.
Yeah, thank you, Tanu madam, for case series of the week, and you have clearly emphasized that you should not mix TB mimics. If you have a doubt, again do a biopsy, which is rather than starting empirical therapy. The message is very clear. Thank you once again, Dr. Pramod sir, Tanu madam, all the seniors for your excellent discussion. Thank you, one and all. So I think Chetan will bring in a new person. Madam is exhausted probably.
No, she has plenty of cases here.
That is her modesty that she is offering somebody else.
Yeah.
Either sir from Belgaum, the Dr. Saab who did from one of the series. I think he has a lot of collection.
Sir has a fantastic collection.
So we'll call sir if possible. And again, madam can come back after 2 weeks.
Yes. Whenever you want. I mean, just for a change. I mean, I'm okay. But if somebody else wants to do it just for change, somebody else can present.
Prajapati sir, आपका collection बहुत रहता ना, Prajapati sir.
Collection तो है. I think left to Manish and Chetan to decide. If they ask, I will do.
I'll talk to Bhaskar sir and Chetan sir.
Yeah. You can decide.
Yeah.
Okay.
Thank you, one and all.
Thank you very much, sir. Thank you. Good night, ma'am. Good night, sir.
Right. Good.
Thank you. Good night.
Good night.
Bye.
Good night.